patient suffering from a tennis elbow always describes pain at the lateral aspect of the elbow, possibly with radiation in a distal direction and sometimes even radiation into some fingers. And they all say the same. They all have problems with extension activities, and in acute cases, because of painful twinges, they sometimes drop things. They are pouring out coffee, for instance, and they just drop it because it hurts too much. So this reflects automatically in the clinical image. What do we find? Well, resisted extension is, certainly in acute cases, very painful and even weak. There's no weakness because of some nervous problem or some rupture problem, but it is just weak because it hurts too much. We repeat the test from a fist position, and this test is also quite painful. And possibly the radial deviation against resistance could be painful, but this is not always the case. A golfer elbow is far less frequent than a tennis elbow, and mostly is also less invalidating. Patients describe some pain in the medial part of the elbow, also possibly with radiation, but mostly not too far. So what do we find in the examination? Well, the resisted wrist flexion is going to be the main positive test. Possibly the resisted pronation in the elbow is also going to be positive, but this is not always the case. If the tennis elbow has a local origin, then the question is, of course, which type of tennis elbow are we talking about? Well, it could be a type 1, and what is a type 1? That's a lesion at the insertion of the extensor carpi radialis longus. The most frequent one is a type 2, and the type 2 is a lesion at the tenoperiosteal aspect, the anterior aspect of the lateral epicondyle of the extensor carpi radialis brevis muscle. Type 3, then we are talking about the tendon of the brevis, and a type which is absolutely not frequent, that's going to be the type 4, is a muscle belly lesion. When we talk about a golfer elbow, then again we have two types. The most frequent one is the tenoperiosteal type, which lies again at the anterior aspect of the medial epicondyle, and possibly a lesion at the musculotendinous junction.